That's the heads up. Again, how do you start? How do you end? Well, thanks for meeting. I want to confirm you got the letter or my call that describes why we were getting together. A lot of the time the individual says, yeah, I think I remember getting a letter. So you always take two copies with you, one for you, one for them, in case they forgot where they put it, or they know darn well where they put it. I just feel the need to review some performance issues that just don't appear to be consistent with our commitment to excellence. I respect you. I want to hear your view. What I hope you'll do is take some time to reflect. Again, reflect. I'm not going to fix it for you. It's still a respectful, I know you to be a great problem solver, and I'm confident you'll figure this out. I also liked the comment before that, we also have resources. And I hope you'll call on those resources. And those resources may be obvious, in which case you can refer folks to local resources. But as much as I appreciate your contributions, I've just got to share with you that we've got standards that we ascribe to, and I know you're going to follow those. But I know some of you in this room are researchers, and so if you'll permit me the luxury of just 2 minutes on research, you've got to be asking yourselves, all right, this sounds mostly okay, but is there any evidence that it actually works? The med-mal research background's clear that some physicians are associated with more than their fair share of suits, and that high risk today is high risk tomorrow. And there are citations. And it's these patient complaints that got us started at Vanderbilt, because we were able to show clear association between the complaints that patients were making and lawsuit risk. So Dr. Pichert was demeaning to the nurse and us, pushy, a real know-it-all, arrogant, flippant, didn't listen. We're not coming back. Dr. Pichert left me, walked down the hall, said to the nurse, this patient's completely messed up my day. Go give them that information packet, get them out. That in every medical group, and we've worked with about 90 medical groups, on the left-hand side of that curve, a third to a half are never ever associated in a 4 to 6 year period with a patient or family concern about their interactions with that doctor, with any of those doctors. But then there are 10% who are associated with fully 50% of all the patient and family complaints associated with concerns about physicians. And it turns out, very briefly, there's a citation at the bottom, but if you take a look at the groups 4 and 5, they are predicted to be high risk based on patient complaints and some demographic factors, the type of, all those things. But it's the patient complaints that far outweigh all the other variables in a multivariate regression equation to predict lawsuit risk and the amount of money we spend on lawsuits. And that's been replicated in Chicago, it's been replicated in Massachusetts, and it's been replicated in a number of places. So I'm confident that if we can just identify that 80% at the bottom of the total expenses, and it's associated with 10 to 15% of the practice group, then wouldn't it make sense to work with those folks? We get back to the pyramid, and what I'm thinking here now is that an awareness intervention is like those signs. Do you have these in the Philadelphia area communities? When you're driving down the road and it's a 25-mile-an-hour speed limit, you have no idea how long it took me to get this picture. But let's just say that I like to think of these awareness interventions as an opportunity to share one of these signals. I love this analogy because I don't know when I'm going 39 miles an hour whether Smokey is behind a bush a quarter mile down the road or not. I don't know. But I have been given a heads up, and I have been given an opportunity to behave differently, right? And probably 98 times out of 100, Nothing bad's going to happen. I'm not going to get in an accident for speeding. I'm not going to get a ticket. I'm not going to get in trouble. But you know, does it increase the chances that I'll get a ticket or be in an accident if I'm behaving outside the parameters? Yeah. So I hope in the spirit of sharing with a colleague that you're going a little faster than the speed limit is the spirit in which you will take these. And so what we do is we give folks the letter, we share with them bar graphs of what number types of patient complaints, a risk score we calculate. We show them we've got 40,000 physicians in our national database, and we're accumulating it on nurses now because we've started with physicians, which was our commitment. But the good news is that these folks who really stand out sometimes just need to know that even among their peers, they stand out, and that it's not just the system in which they work. Can help. We've overseen these kinds of communications with 950 physicians, and I've got follow-up data for 2 years on 750 of them. The good news is that just by sharing that you stand out, 76% of them, 3/4 will turn it around and their patient complaints will fall back to the group norm. It's very impressive. These are outstanding, dedicated professionals. Well, if it's 3/4, that leaves the other quarter. And some of them don't improve. Some of them actually go on to get worse. And that's why you need to have the next level up on that pyramid that we're not going to talk about today, except for that edicts mnemonic that I shared earlier. And then some depart. They take what's called the geographic solution. I count those mostly as failures. The good news is that some will depart improved. The thing that's impressed us is that back when that risk manager took Dr. Hickson and me aside and said, "You're doing great research," we said, "Well, what are the data that concern you?" And it was these. The gold line up there are the Middle Tennessee physicians insured by the insurance company that insures most of the non-academic physicians throughout Tennessee. And we were certain, being the arrogant Vanderbilt people that we are, that our data would be better. But ours was the black line. We were 20% higher than our colleagues, many of whom were our former students. And that first green arrow is when we started sharing these data on patient complaints. And you can see that the black line has gone down and down and down. The number of lawsuits per 100 physicians has just fallen dramatically. Whereas for our colleagues in Middle Tennessee, the line is down about 20%, which is sort of the historical trend line nationally. True also in Pennsylvania, by the way. And they spiked up when we had some modest tort reform. I know you've had a lot of tort reform and issues with it in Pennsylvania. But we already knew about these events, and our pattern has been really rewarding. And I say that in a monetary way also, because, like I said, we're self-insured, so it's our money going out the back door. And that's why sometimes the rainmakers don't appreciate how their behavior causes losses in staff turnover and risk management losses and some other challenges. Can the process be adapted? I want to conclude with a story today. I'll just take 2 minutes to do it because it's time for lunch. 57-year-old with arthritis, bone on bone, bilateral knee replacements. Surgery goes well. What are the potential risks? Well, of course, infection is one of the risks. And if you knew that you were at an organization like mine whose hand hygiene rates were down in the 40s and 50%, you would be concerned for your loved one, as was said earlier. And you have to go through a lot of pains to do everything that's required in order to make sure that a hand hygiene campaign is successful. And so you have to have all the marketing and scorecards and observers and all of the things that the CDC and other groups suggest. And if you were the manager of that unit on the right, and there's 100 other units in the green zone on the left, if you were the co-medical nursing unit managers, we have co-governance, co-management of all our outpatient and inpatient units. And if this is your outpatient, inpatient unit where that arrow is pointing, and you're nowhere near the goal rate for hand hygiene, wouldn't you want to know and get one of these awareness heads up? And the good news is that by doing that, the goal adherence rate's 92%. We've ramped it up every year. And so the good news is that about 2/3 of the units have been successful in achieving the goal. Another quarter have been getting there, and some others need some more help. But look at this trend line on the hand hygiene, secret shopper observers. And I know secret shopper observers drive you crazy, because wouldn't it be better if they just took you aside and say, remember, wash your hands? Well, we do that too after we succeed in getting to goal with units. The important thing is that red bar represents when there was the regular feedback to the shared governance managers. And when we've had good months of hand hygiene, the infection scores are in the bottom right-hand corner. And when we've had poor hand hygiene, you can see the results on infection rates in the upper left. So there's a high correlation. Now it's your turn. Your homework is to go out and do good work. Take a look at the handout. Your role as leaders is to understand what contributes to threats to safety. It's your role as leaders to begin to encourage non-punitive, non-directive reporting. Your role as leaders is to take advantage of those things that JP and the others are going to lay before you this afternoon in order to promote the kind and quality of care that Einstein is already famous for, but probably can be even just a little bit better. Who's going to dismiss us to lunch? Is that you, Dr. Cohn?
We want to thank Dr. Pichert for